Hi, my name is Grant, and for our clinical site, we're at Central Park. I'm here to give you a health history on our patient, Miss Grace. She is an 88-year-old female who is Caucasian, admitted to Central Park on February 26, 2019. Diagnosed with absolute glaucoma, dementia, depression, anxiety, hypertension, and pseudobulbar. Patient presented when she was admitted with good energy level, sleeps well, normal appetite, didn't really exercise any days of the week, normal bowel and bladder, but something that was very apparent was memory loss and anxiety and depression upon arrival. Patient had shown no signs of, had no past surgery procedures, and had no known allergies. Patient had not previously smoked or used any type of tobacco products. Patient had also not used any alcohol or any other drugs. Patient was on several medications: benzapril, Lexapro, Seroquel, Ativan, to name a few. Next, Patrick is going to talk about the physical exam and lab diagnostic.
Hello everyone, like he said, my name is Patrick, and I'm going to talk about physical exam, lab results, and other diagnostic tests. On physical exam, the head was found to be normocephalic and traumatic. The trachea is midline, her vision is decreased, and she wears corrective lenses. The pupils are equally round, reactive to light and accommodation. Miss Grace has no trouble hearing, and she does not wear hearing aids. All cranial nerves are intact. Patient is oriented to person, but not oriented to place and time. And most of the time, the patient is confused and she lacks judgment regarding everyday life. On mental status exam, the patient was found to be depressed, anxious, and sometimes agitated. Chest and lungs exam revealed the chest movements that are equal and symmetrical, and breath sounds are clear bilaterally on auscultation. The cardiovascular exam found S1 and S2 to be normal, and apical pulse was regular too. The abdominal examination was done, and the abdomen was soft, and no tenderness was noted. The bowel sounds were present and within the normal limits. Peripheral vascular examination revealed that all peripheral pulses were palpable and symmetrical. The patient's skin was warm and dry to the touch, and no lesions or rashes were noted. For lab results, I only mentioned the lab results that were below or above normal ranges due to limited time for this presentation. The lab results that I'm presenting are the most recent results. The specimens were collected in April in 2019, and the results came out the same day. Glomerular filtration rate for non-African American was 52, which is below normal limits. Calcium levels were 8.3 milligram per deciliter, and this was below normal ranges as well. Total protein was found to be 5.3 gram per deciliter, and this was below normal ranges. Albumin was at 3 gram per deciliter, and this was below normal limits. Red blood cells were below normal ranges as well, and it was 3.82 thousand per cubic millimeters. Hemoglobin was also below normal ranges, and it was 11.9 gram per deciliters. Other lab results that were not mentioned were normal. There's no other diagnostic test that was done according to the patient's chart. The next person is Mary, and she'll be talking about the medication that our patient is taking. Thank you.
All right, guys. My name is Mary. I will be presenting Mrs. Grace medication. Mrs. Grace is currently in benazepril, quetiapine, sertraline, as well as lorazepam. Benazepril is a medication that is used to treat lower blood pressures by specific inhibition, ACE, and thus by decreasing angiotensin. Benazepril is used to, as I stated before, is used to treat moderate hypertension. Patient that has renal impairment, hypovolemia, CHF, diabetes should use benazepril cautiously. The adverse effect of benazepril are headaches, dizziness, fatigue, weakness, hyperkalemia, nausea, diarrhea, or constipation. The nurse should assess for hypotension, especially in patients who may be volume depleted and that have recent vomiting, diarrhea, salt restriction, and also patients who have CHF, which is known for congestive heart failure. The nurse should also assess the patient lab tests, such as serum potassium levels for hyperkalemia. The nurse should educate the patient to not use salt substitute unless recommended by the doctor. The nurse should educate the patient and their family to report swelling on the face, the eyes, the nose, the tongue. Also, the patient that have difficulty breathing should also report to the doctor. The patient should also educate the nurse should also educate the patient to not breastfeed while taking the medication without consulting the physician. The second medication that we're gonna touch on is quetiapine. Quetiapine is an antagonized multiple neurotransmitter receptors in the brain, including serotonin as well as dopamine. This medication is an antipsychotic medication that is used to reduce psychotic behavior. Patients that have liver function impairment, cardiovascular disease, hypertension, dehydration, treatment with antihypertensive, history of seizure or suicide, breast cancer, Alzheimer's, Parkinson's disease should use this medication cautiously. The adverse effects for this medication are fever, hypertonia, flu, postural hypotension, tachycardia, abdominal pain, constipation, and such more. The nurse should monitor patients that have diabetes. The nurse should also withhold the drug and immediately report for tardive dyskinesia or any neuroleptic malignant syndrome. The nurse should also assess the lab tests for the patient, such as liver function, lipid profile, and thyroid function. The nurse should carefully monitor blood glucose level if the patient is diabetic. The nurse should educate the patient to exercise cautiously with potentially dangerous activities requiring alertness. Also, the nurse should educate the patient to avoid alcohol consumption and activity that may cause overheating and dehydration. As well, if you are breastfeeding, you should also do not breastfeed while taking this medication. The third medication that we're gonna touch on is sertraline. Sertraline is a potent inhibitor of serotonin reuptake in the brain and chemically unrelated to TCA. This medication is treat depression, OCD, anxiety, and bipolar panic disorder, as well as bipolar disorder. Patients that have seizure disorders, liver dysfunction, renal impairment, recent history of MI or cardiac disease, dehydration, DM1 and 2 should use this medication cautiously. The adverse effect of this medication are hypertension as well as hypotension, edema, syncope, tachycardia, fatigue, incoordination, vertigo, and such more. The nurse should supervise patient at risk for suicide closely during initial therapy. The nurse should monitor for worsening of depression, of suicidal ideation. Also, the nurse should monitor patient with a history of seizure disorder. The patient and family education. The nurse should educate patient to report nausea, insomnia, dizziness, headache to physician. Report signs of bleeding to physician whenever taking concomitant warfarin. The patient do not breastfeed while taking this drug without consulting their physician. The last medication that we're going to talk is lorazepam. Lorazepam is an anti-anxiety medication that is used to treat mild sleep, as well as for example, if the patient are going to surgery, the doctor usually give that medication to the patient to reduce any anxiety that the patient may have. Patients that have renal or hepatic impairment, brain syndrome, suicidal tendency, GI disorder, as well as pulmonary reserve should use this medication cautiously. The adverse effects are depression, sleep disturbance, restlessness, confusion, as well as weakness. The nursing implication are the nurse should supervise ambulation of older adult patient for at least 8 hours after taking lorazepam injection to prevent falling and injury. Also, as stated, to ambulate patient, this might cause swelling, and the patient might be at risk for skin integrity. The nurse should also supervise patients who exhibit depression with anxiety closely, with the possibility of suicide exist. The nurse should educate the patient as well as their family to not drive or engage in any hard activities for at least 24 to 48 hours after receiving an intramuscular injection of lorazepam. The nurse should also educate the patient and their family to not drink large volume of coffee. Do not consume any alcoholic beverage for at least 24 to 48 hours after an injection, and avoid when taking an oral regimen. The patient should also educate the nurse should also educate the patient to not breastfeed while taking this drug. This is all I have for you, and the next one will be Mrs. Herney that will be present the pathophysiology next. Bye.
My name is Grace, and I'm going to be talking about the pathophysiology of Miss Grace's mental illnesses. First, I'm going to talk about Alzheimer's disease. Alzheimer's disease is one of the most common and well-known forms of dementia. It is a progressive neurological degenerative disease of the brain that is characterized by significant changes in brain tissue. In patients with Alzheimer's disease, there's a deficiency in the cholinergic function in the cortex and basal forebrain, which leads to decreased cognitive function. Neuropathological hallmarks include amyloid plaques and neurofibrillary tangles. There's a significant loss of neurons along with shrinking of larger cortical neurons. There's no cure for dementia. There's only symptomatic treatment. The goal of drug therapy is to slow down the loss of memory and cognition as a way to keep patients independent as long as possible. Risk factors for developing Alzheimer's disease is increasing age, so over 65 years old, family history of Alzheimer's disease. The strongest genetic risk is involved with the apolipoprotein E4 gene on chromosome 19. Women are more likely to develop Alzheimer's disease than men are. Clinical presentation of Alzheimer's disease first begins with amnesia. It is one of the first symptoms to be experienced. Also, language, perceptual skills, reasoning, and personality are all affected, and they are often noticed by family members. Memory loss can begin with anomia, which is the forgetting of names of things and people. Memory loss typically begins with short-term memory before long-term memory. it often works in a backwards fashion. A good example of this is that Miss Grace cannot remember what she did yesterday, but she's able to remember things that happened 40 years ago. An individual with dementia can demonstrate poor judgment, lack of ability to reason, and inability to think abstractly. In severe dementia, individuals often have difficulty remembering or recognizing relatives and caregivers, and have problems with language. A good example is that Miss Grace often has trouble finding the correct words that she wants to say. To diagnose Alzheimer's disease, in taking an MRI, the hippocampus has a decreased size, beta amyloid plaques can be noticed on PET scans, and in a lumbar puncture, the cerebrospinal fluid can demonstrate tau and beta amyloid proteins. There is no cure for dementia, there is only treatment of symptoms. There are pharmacological and non-pharmacological treatments that are used. Medications such as antipsychotics, mood stabilizers, serotonergic drugs, and stimulants are often used in patients with Alzheimer's disease. Medications are also used to slow down the rate at which the memory loss symptoms worsen. For non-pharmacological treatments, it's important that the patient's routine remains stable. Music and artwork can provide a sense of consistency, photos to remind them of people and places of the past. Miss Grace also struggles with anxiety and depression. Anxiety is a normal human emotion. It becomes a pathological condition when it is excessive, uncontrollable, and triggered by no external stimuli. Patients with generalized anxiety disorder have increased levels of fear and worry that are difficult to control. Miss Grace is consistently worrying if her father is alive or not, if he is healthy or not, which is a sign of her anxiety disorder. She also has depression. Depression can present with feelings of sadness, loneliness, irritability, worthlessness, hopelessness, agitation, and guilt. We have seen all of these symptoms in Miss Grace. She can have a daily sad mood, changes in weight, diminished levels of concentration and decisiveness, and fatigue or loss of energy. Miss Grace has episodes of severe agitation and irritability. She also has episodes of extreme sadness where she walks around the site sobbing. Family history, and there is a family history and genetic component of depression. Individuals with depression may have a mutation in the serotonin transporter gene on chromosome 17. Depression is associated with decreased metabolic activity in the neocortex of the brain and increased activity in the limbic system. There are disturbances in reduced serotonin, norepinephrine, and dopamine. Alzheimer's disease can cause depression, and depression and anxiety are often linked together or found together in patients. All of her mental illnesses build off of each other and can worsen symptoms. Up next is Alex, who's going to be talking about analysis of data.
My name's Alex Carson, and I'm going to be presenting analysis of data for our patient in our clinical rotation today. Miss Grace was born on December 31st, 1930. She is 88 years old and a Caucasian female. So, a little bit of background on this patient. She came in diagnosed with dementia, anxiety, hypertension, and pseudobulbar. Recently, she's been declining more and more, having more frequent episodes of her uncontrollable crying and acting out. The patient has become very confused and she doesn't really know what's going on. At times, she's very disoriented and acts out. When we first came to this clinical rotation, our first clinical here, we were having residents participate in activities, and this resident was participating in the activity that we were doing that day. She was very communicative, very active, like participating with the residents a lot. She was in a very good mood, no outbursts or anything. Her family came in and they did not want to interrupt her because this was a good day for her, and they were scared that if they interrupted her and took her away from this activity, that it would trigger one of her uncontrollable episodes of crying. Within the past couple months, she has been recently increased on her dosage of Seroquel. This has triggered more and more episodes. She's just been crying frequently for no reason. So since this has been happening, her family requests that the patient be removed from her medications because they felt like she was being chemically sedated. So as a result of this, she was removed from her medications, including benzapril, Nuedexta, quetiapine, sertraline, and lorazepam. They immediately stopped her off these medications, not slowly decreasing it, and this resulted in the patient having a very bad episode where she was trying to hurt faculty, other residents, and herself. So they immediately transported her to the hospital, and from there she was transferred to another facility. The recent lab values were taken on April 11, 2019, and they stated that she had a low GRF of non-African American, a low level of calcium, protein, red blood cells, and hemoglobin. After careful analysis of this data, we agreed that the patient should not have been on an increased dosage of Seroquel due to the fact that this can increase the mortality rate in elderly patients with dementia-related psychosis. The actions that should have been taken instead should have included either decreasing the patient's dosage of Seroquel or slowly discontinuing it over time instead of immediately cold turkeying it and just taking her off of it. The consequences of taking the patient off of Seroquel suddenly resulted in her psychotic breakdown and caused the patient to become extremely irritable and nauseous, when this could have been avoided if you just slowly decreased the medication or just decreased the dosage in general. So she wasn't having these psychotic breakdowns and uncontrollable episodes. For the next part of our presentation, Elena is going to present the plans for action and consultation for appropriate sources of plans.
Hi, my name is Elena, and I'm going to be going over Miss Grace's plans for action and consultation of appropriate sources for her plans. Miss Grace's primary diagnoses include unspecified dementia, anxiety, depression, and pseudobulbar affect. When we first decided to use Miss Grace for our oral presentation, she was still a resident at Central Park. However, the week before we recorded this presentation, her status significantly changed because she was taken off her current medication regimen as her condition was not improving. Since her arrival at Central Park in February, her confusion, agitation, and crying had worsened, and her medication regimen was stopped because the concern was brought up that she was chemically restrained by her daughter. When her medications were stopped, she became upset and aggressive towards other residents. The precipitating events of taking her off her medications because of her continued declining state, paired with her reaction, given the level of antipsychotic, antidepressant, and anti-anxiety medication she was on, prompted intervention, hospitalization, and re-evaluation of Miss Grace's status and medication regimen. So although her plan of action changed from what it would have been if she were here to her current state in another facility, we can still review possible plans for action and nursing care in her specific case. Firstly, because her medication regimen was changed and she is undergoing re-evaluation, her nursing care plan will focus on monitoring her behaviors and reactions to medications. Generally, her plans for action and care will be determined by consultation of appropriate medical specialists, including a team physician and psychiatrist, with the goal of restoring her to a state where she is calm and as close to as coherent as she was when she was at Central Park. Specifically, plans for action will revolve around her nursing diagnoses, which include diagnoses related to her conditions of dementia, depression, anxiety, and pseudobulbar affect. Specific nursing diagnoses include disturbed thought process, chronic confusion, impaired verbal communication, self-care deficits, including bathing and dressing, wandering, risk for injury, and many others that reflect her changes in cognitive abilities, disorientation, and dementia. The plans for action and nursing interventions surrounding these nursing diagnoses will include assessing her thought process at each shift and observing for changes in cognitive functioning, memory, disorientation, difficulty with communicating, or changes in thinking patterns. When Miss Grace was at Central Park, there were times when she was very oriented and engaged and was able to communicate and participate effectively in activities. There were also other times when she was intrusive, hysterical, and her communicative dialogue did not make sense. When administering the mini mental exam to her, she was able to read and draw at multiple points during the assessment, but was also incomprehensible and considerably confused and disoriented at others. Her levels of confusion and disorientation should be noted and addressed as often as possible, since her diagnoses are primarily neurocognitively related. Nursing plans for action will involve being observant of these changes to see if there is any patterning or changes and making note of it accordingly. Because Miss Grace was moved from Central Park to another facility and was also hospitalized, her ability to cope with events and change should also be evaluated. She likely will need to be oriented to her new environment through regular routines, patterns, and possible reminder of past events or individuals in her life. Although we knew that her daughter came and visited her often, we were never actually able to witness Miss Grace recognizing her daughter. However, she always kept close to her roommate and was able to interact and verbalize in coherent conversation with her table mates. As such, opportunities for social interaction and activities should be available but not forced upon Miss Grace and her nursing care plan. When interacting with Miss Grace, there were times where she appeared to be thoroughly enjoying herself. Activities that promote lucidness, communication, and lack of negative behavior should be promoted. Aside from the plans for nursing action surrounding her cognitive function, as nurses we also need to take note and plan for her physical care. Although Miss Grace was ambulatory and able to feed herself, she will likely need additional assistance in her current state. Activities such as bathing, dressing, and self-care and hygiene will likely need to be addressed. Her current state should be assessed to see if she's able to maintain the level of care for herself that she was able to carry out at Central Park. Any changes that indicate decline should be noted, and her care should be adjusted accordingly. Specific examples include watching her for wandering or addressing safety issues if she is still freely ambulatory. Her environment should be kept clean, controlled, and safe. Similarly, her past behavior of becoming intrusive and belligerent should elicit proper safety protocols and precautions. Because her cognitive function is impaired, she should also be assessed for possible dehydration and nutritional deficiencies, any impaired skin integrity, and any changes in vision and hearing. Her pain and discomfort levels should also be monitored and assessed because it may be difficult for her to verbalize and communicate them. Her musculoskeletal functioning should also be monitored to take note of any weakness and loss of sensation or muscle spasms that could be indicative of neurological changes or other physical problems. Overall, proper and complete physical and mental assessments should be given as often as possible given her current unstable state. Consultation of appropriate sources for evaluation include her chart, evidence-based nursing practices related to the specific care plans for actions that were just highlighted, and the biopsychosocial model to assess her physical, biological state, psychological state, and socio-environmental factors such as her location and support network. Lastly, although I touched upon consultation of the physician and a psychiatrist, appropriate consultation of multiple professionals should be incorporated into Ms. Grace's care plan. Because her physical and mental status are in states of instability, she will likely need to be seen by geriatric or Alzheimer's specialists or other neurocognitive specialists that have experience in pseudobulbar affect, dementia, and depression. Her medication will need to be prescribed and managed by a psychiatrist. Although her problems are primarily brain-related, physical and occupational therapy will likely need to be consulted to keep her risk of falling or developing weakness and problems in ambulation at a minimum. Consultation with a dietitian and speech pathologist may also be considered. Lastly, because of the extensive problems of care and the level of her family's involvement, a social worker will likely need to be involved in planning and executing her future care plans. This concludes our presentation on our patient, Ms. Grace. We enjoyed learning about and interacting with this client, the other residents, and staff at Central Park. Our clinical instructors' oversight and guidance, as well as working with one another, promoted a positive learning experience that we will continue to build upon in our clinical experiences. We hope you enjoyed our presentation.
Bravo!